think we should start. We're probably still going to have some people joining. A very warm welcome to the University of Surrey, remotely from myself. I'm Kath Taylor, Professor of Healthcare Workforce Organisation and Wellbeing in the University of Surrey, where I co-lead the Workforce Organisation Wellbeing Group with Jill. Who's waving, and we co-led this project that you're here to hear more about today, to hear the findings, and we're launching the guide today. So it's the Care Under Pressure 2 project about psychological ill health in nurses, midwives and paramedics. And the reason it's called Care Under Pressure 2 is that it follows Care Under Pressure 1, which was just called Care Under Pressure, which was focused on doctors and led by paramedic, if you want to give a wave, and Daniele Carrieri, who are also members of the Care Under Pressure 2 group. So that's just setting the scene for why it's got a 2 in it. You may have wondered that. Well, I'm not going to introduce everybody else now, but we are just going to run through what's going to happen in this webinar. So I don't know if are you sharing your slides? Sorry, Jill's going to share the slides. So in a second, I'm going to hand over to Jill, and Jill is going to talk through the project and launch the guide to you. You have a Q&A box at the bottom instead of the chat function that you may be familiar with. So please do feel free to put questions in there throughout the webinar. We have set aside at least 30 minutes at the end to answer questions. So we may save the questions until then, but if they're ones that we can answer in the background as we're going along, then we will do that. So please feel free to use that. As I said, we're recording the webinar. So we're going to present the findings, and then we have 6 speakers for you from a range of backgrounds, of course, nursing, midwifery and paramedic science, but also we have speakers from NHS employers, NHS England and Improvement, and representatives of chief people officers to speak to you about their reflections on our guide. And they'll speak for about 5 minutes each to try and give some feedback to us, really, and some reflections on how it's landed and what it means for them and their practice. So without further ado, I think I'm going to hand over to Jill. And as I say, thank you very much for sparing the time at this busy time of year to come to our webinar. We really appreciate it. Thank you.
Thank you, Kath. So welcome everybody from me too. As you can see here is the agenda that Kath's just run through. And we are launching the guide today, and also it's going to be on our new website. So at some point we'll put the website link in the Q&A so you can see that. So why are we here today? Well, this is the team. Kath's already introduced Karen Matic and Daniele Carrieri from the University of Exeter. Simon Briscoe is our information specialist, can't be with us today. Justin Jagosh, our research fellow, and Naomi Klepatz, the research fellow also from the University of Southampton now, so she was at Surrey when we did the work. Justin. So that's who we were, and we were an NIHR funded study, a realist synthesis, which means reviewing the literature in a particular way that I'm going to come on and explain. So what's the background to this work? Why does it matter? Well, we know that caring for patients and their families takes great courage, compassion and emotional resources, and staff can only care well if they feel cared for themselves. So we also feel that solving the current NHS crisis depends really on making sure that healthcare staff have what they need to do the job well and can thrive and flourish. And this requires optimal psychological health. And you might expect us to say that, but we feel this is absolutely at the heart of healthcare work, and organisations really need to pay optimal attention to this to retain staff and to give great care. Nurses, midwives and paramedics, why them? Why have we focused on them? As Kath said, Care Under Pressure 1 was focusing on doctors. I'm a nurse by background, and we felt that it was important to look at these staff groups, but also because they collectively comprise over half of clinical staff in the NHS, so really important. And they also have some of the highest prevalence of psychological ill health. Staff survey in 2022 gives us a bit of a picture of some of the poor well-being, psychological ill health in the workforce. So we know that 45% of staff have felt unwell because of work-related stress. 57% report going to work despite feeling not well enough to perform their duties, so-called presenteeism, and 34% of staff stated they felt burnt out because of their work. And when examined by profession, the rates are highest in nurses, midwives, and paramedics. We await the 2023 results. I'm sure they'll be with us soon. So we argued and understand from our previous work, but also from our understanding of the literature, that improving staff working lives matters. I mean, it's a moral duty. Employers have a duty of care to staff. We know that there's a link between staff experience and quality of care, and I've led some of that work myself. It affects staff recruitment and retention, and looking after staff is good business practice. Other organisations outside of health know this well and put staff first, and know that if you look after staff well, they will both stay with you but give good customer care, and in the case of the NHS, good patient care. So we're presenting findings from an NIHR-funded realist review on this topic, and the findings we're presenting are used to build the guide, and I'm now going to present the guide to you, which we're launching today. Our NIHR report is not yet published, and I'll come back to that at the end. So our research questions were, why is psychological health in healthcare professionals still a huge and growing problem that's become entrenched in some settings? Why are we still here? Why are we still talking about this? And why, despite multiple interventions, some of which have an evidence base, do the problems of staff stress, distress, and burnout still persist? We know there's quite a lot of what to do, but these issues still persist. And how can leaders and managers use these research findings to help staff to thrive at work? So the evidence base, what did we do? We reviewed 204 pieces of evidence, placing the understanding of context, and that's what realist evaluation does, at the heart of the analysis to gain a deep understanding of psychological ill health in the workplace, what causes it, what form it takes, who is most affected by it and in which circumstances, and why psychological ill health persists despite the existence of interventions to mitigate it, as I've said. The result, we would argue, is a more nuanced understanding of the problem and potential solutions than any previous work in the field. So we're asking what works, how, why, and for whom, not just does it work. So why did we take realist methods? As I said, it goes beyond does it work and asks why and how, and for whom, and any different circumstances. And healthcare is a space where how and why interventions should work are often poorly explained. So unpacking this enhanced our knowledge of how interventions can be improved. And we're hoping we've dug a little bit below the surface and really giving you some insight today into some issues that perhaps you probably all instinctively know, but haven't had collected together in this way and presented in this way. And we're hoping it will give you some new insights. So we involved many stakeholders, some of whom in the audience today, but some of whom are also speaking today. We involved patients and the public, nurses, midwives, and paramedics, and the regulators, policymakers, academics, and representatives of NHS England, one of whom is here today, Sian Kitchen, who's going to speak. So this is the guide. This is what it looks like. We've worked with graphic designers and illustrator to try and make it user-friendly and accessible. We want it to be used. We want it to be easily understood and pick up off the shelf and go use. So let's hope we've achieved that. So what does the guidance tell us? Well, the scope of the guidance, it gives us some key overall insights. What are our key findings overall? It gives 5 key findings. And then we unpack these conflicting priorities and tensions, the things we want to talk about that are acting against each other, and I'll come back to that. We also present how to make a change, 6 key recommendations for change, and then what you can do. There's 3 sections, what you can do as a senior team leader, a nurse, a midwife, a paramedic, and as board members and senior staff. So just going to go through some of the overall findings. So what we did find, which was a little bit surprising, was that there were more similarities between the experiences of nurses, midwives, and paramedics than differences. We chose these groups and we looked at them individually, and we thought there might be some profession-specific issues. And what we found was it wasn't. So few interventions, therefore, need to be profession-specific would be our recommendation and our finding. But what we did find was that some causes may be more prevalent or exacerbated in certain professions. And so they're those with a high exposure to trauma or at different career junctures, or where the role aspects place them at greater risk. So, for example, newly qualified staff and lone workers. So it might be that nurses in the community, as well as midwives in the community, and paramedics going out working alone as advanced paramedics might find it much more challenging when they're on their own and they haven't got opportunities to share with colleagues and be in a team, for example. Usually the surface architecture, as we're calling it, and what we mean by that is features and structures of the job and the workplace, the work environment, increases risk rather than the profession itself. And what we also found is where interventions are not working for staff, and we saw this particularly in the pandemic, staff create informal interventions to plug the gaps. And these are rarely mentioned or recognised in the literature. So some individual characteristics like ethnicity, sexual orientation, gender identity and disability deserve greater focus to improve understanding of causes and interventions. We didn't find enough about that in the literature. Psychological well-being is largely presented as a responsibility of individual staff. And I'm sure most of you will know this, but we would argue greater emphasis on shared responsibility between individuals, teams, managers, organisations and governing bodies is required. And then these tensions that I've talked about, there are tensions between aspects of work that are incompatible or work against each other and that contribute to psychological ill health or prevent interventions from working effectively and lead to a workplace system that is what we would say is imbalanced. So I'm going to go through the 5 key findings first. So the first one is we would say it's difficult to promote staff psychological wellness where there's a blame culture. And so we found there were tensions between a lack of shared accountability, which blames individual staff for errors and enacts double standards, versus a team or system-based approach. That there's a need to raise concerns to improve conditions and patient safety versus fitness to practice processes becoming an oppressive force. So sometimes if concerns are raised, it can result in that person being bullied and blamed and referred to the regulator. And that can be quite a blunt and oppressive instrument. That an inclusive learning culture and encouraging staff to speak up versus a blame culture and what's so-called the deaf effect, which is where concerns are raised, but there is no action and they appear not to be heard by managers and leaders. So when there's some inaction when concerns are raised. So there are the tensions in that first key finding. Key finding 2, serve and sacrifice. The needs of the system are often override that staff psychological well-being at work. Sorry, I just spotted a typo there on the often override staff psychological well-being at work. Amazing the number of people who've looked at these slides and we didn't see that. Apologies. There are tensions between a professional culture that promotes a serve and sacrifice ethos, which persuades staff to prioritise institutional needs and patient needs, rightly so, but institutional needs, versus a culture that values staff and promotes self-care. That supporting existing staff in the context of staff shortages versus the normalisation of overwork include a perceived coercion to fill vacant shifts beyond contracted hours. So of course we all know that you need enough staff, but actually when you're saying look after yourself and well-being is important versus what we saw in the literature, some staff being begged to come in on shift to fill vacancies, those two are at odds and that's where the tension is. And the lived reality of staff shortages and the normalisation of overwork versus the wish to deliver high quality patient care, which can result in moral distress. So again, putting patients first, overwork and going above and beyond really can be counterproductive to staff wellbeing. So our key finding 3, that there are unintended personal costs of upholding and implementing values at work. So we found that the reality of healthcare delivery versus the taught theory and values that might be inculcated in education or that people might come into the profession to do can lead to guilt and moral or emotional distress. And the benefits of staff empathy to patients, we all know that patients want compassionate care and empathic care, can cause harms to staff. So being so empathic can increase vicarious trauma and unhealthy coping strategies. and that the excessive requirements for emotional labor in our work, this type of work, can result in the suppressing of emotions, versus the need to improve workplace psychological ill health. So it's quite hard to suppress emotions and actually look after your psychological ill health. And it's another way of putting yourself second rather than putting yourself first. So the interventions we found were fragmented, targeted at individuals, insufficiently recognized cumulative chronic stressors, and that there were tensions between the focus on individual staff, and we found a lot of that in the literature. A lot of interventions are focused on, you as a nurse do this, look after yourself, you need to be more resilient, etc., versus singular fragmented interventions versus the focus on systemic issues and multi-level solutions, which we are arguing is absolutely crucial. Our main argument here is that it needs a systemic solution, and individuals should not, obviously individuals do need to look after their own psychological well-being, but not only them. It needs a wider team-based and organization-based approach. And that the focus on acute episodes of trauma, so being reactive to things, versus the need to recognize and support chronic cumulative stressors, so that the final straw may come over time with lots and lots of chronic cumulative stressors, not perhaps a single event, and that's not always recognized in interventions or in the literature. And in terms of designing and implementing interventions to work optimally for diverse staff groups, we found there are tensions between making staff wellness interventions mandatory versus voluntary, and the need for psychologically safe spaces to debrief with managers or leaders so they can hear staff experiences and can then offer support, versus the need for peer-led spaces without managers for debriefing. So that's quite a tension there, really. And also the need to act and offer support versus providing interventions that are ineffective because they take place too soon, are reactive, or are one-off activities, that they don't go long enough or recognize these chronic cumulative stresses, as I said earlier. So in terms of delivering healthcare, we're arguing it's quite a complex balancing act. And in terms of the tensions, we're arguing that from what we've read in the literature and our analysis, that there are tensions between providing this prompt, high quality, person-centered care for patients, which we all desire and which our organizations want us to provide, while meeting the needs of a workforce, is a complex dynamic balancing act. And it often results in conflicting priorities and tensions, with work towards one goal pulling against the next. For example, asking staff to put patients first can require them to put their own health and well-being second or lower on a list of priorities. So I'm just going to walk you through these tensions again. So the current priorities, we've got these little jigsaw diagrams here. It's quite hard to represent these complex ideas visually. But what we've got here are jigsaw pieces, and at the top is the current priorities are shown in the top jigsaw piece for each figure, with the bottom jigsaw piece showing corresponding change that needs to be implemented to restore the balance. And these areas of tension must be redressed if we are to develop a healthy workplace where staff can thrive. So what we're arguing is that high standards for patient care, which is a given, need to be matched by high standards for staff psychological well-being. We need the two in tandem. They need to be parallel, not that one is prioritized over another. They are partners. And that professional accountability needs to be matched by a listening learning culture. So of course we need to be professionally accountable, but when things are going wrong or when there's a culture that needs changing, there needs to be a listening learning culture, and people need to be able to speak up and be heard. Thirdly, that the reactive responsive interventions need to be matched by proactive preventative interventions, and that an individual focus needs to be matched by an organizational focus, as I've said. So these are our four key tensions. And here we have what we've called our overall program theory, and they're the four tensions that I've just walked you through, all put together in one diagram. So across the top is currently what happens, and across the bottom is what we're recommending needs to change and needs to happen more. Another way of moving on to recommendations now, another way of representing this is in this tree diagram. So what we're arguing here, we've got 6 key recommendations. There are more in our big report, but so we're arguing that if you look at the bottom of the picture and the roots, so if we prioritize employees' essential needs, and it's extraordinary that in 2023, I'm still having to say this, but adequate rest break rooms, adequate hydration, adequate access to food, parking, all the things that people need to actually get to work well enough to do the job. Those essential needs need to be prioritized, and they're not always so. So at the bottom, the essential needs. Moving up the trunk, we're arguing we need this systems approach to reviewing the provision of support for staff to thrive and develop and share examples of good practice. And then going across the leaves from left to right, we're arguing that it's important to normalise, anticipate and manage psychological ill health. It should not really be a surprise in our professions when people are stressed and burnt out. This is, as I said, complex emotion work in often difficult circumstances. And we should almost anticipate that staff are at some point in their career going to become psychologically unwell, and that we need to anticipate this and manage it from the get-go. We need to identify and nurture future compassionate leaders. And we need to learn from staff, listen to them, create a learning, not a blame culture. And we need to give psychological harm parity with industrial injury and risk. We feel that there's quite a lot at the moment about physical risk and physical health, but not enough, not in parallel, about psychological harm. And that needs to be planned for and acted on. So walking through these recommendations now, which will be in the guide or are in the guide. So in terms of prioritising employees' essential needs, as I've said, access to hot food, hydration, etc. The No Hungry Staff campaign, break rooms that are created for rest and recovery rather than multi-purpose spaces or cupboards, or quite often what I've seen and experienced, not very restful places. That we need to meet work-specific needs, for example, lockers to keep belongings safe or access to showers. And again, surprising that I'm still having to say this. And arranging staff parking with reduced rates and include disabled parking. We were rather surprised to find that there was some shock that there were some staff who might need disabled parking, not only patients. And a suitable space to keep belongings and rest, particularly for those staff perhaps out on the road, like paramedics, that might not have a base, such as remote and community workers. Recommendation 2 is about taking a systems approach to reviewing the provision of support so staff can thrive. So draw on case study examples of good wellbeing bundles showing how others have developed and implemented interventions. They could be pulled together and optimized and accessed. Reviewing gaps in provision of interventions, including those supporting individuals, teams, department and specific professions, as well as organisation-wide options. Develop staff wellbeing initiatives, drawing on staff insights and co-production, involve staff in understanding staff know what they need. Extend the practitioner health programme to beyond doctors and dentists. This has been a long plea and call from others, not yet funded, probably won't be funded at the moment, but we can but try. And bringing together staff from different professions, including clinical and non-clinical staff, for example, together through something like Schwartz rounds, so providing a space. Normalise, as I said, anticipate and manage psychological ill health. So start talking about it early with students. Consider the use of reflective spaces such as Schwartz rounds. We use them with our undergraduates at Surrey. Develop and implement an organisational long-term plan to acknowledge and manage risk of poor psychological health for individuals, but also across the whole organisation. Design and implement staff psychological health personal development plans to anticipate and prevent stress, burnout, and provide information regarding support. And build in protective career breaks. Not everyone can stay in the same challenging environment for a whole career. And people might need to rotate in and out of challenging environments, and that needs to be planned for and not seen as a negative, so people have to leave. And normalise checking in. We know there's quite a lot of stigma around some of these issues, and if we normalise checking in and asking each other if we're okay, that it's okay to not be okay and okay to ask for help is important. As I said, giving psychological harm parity with industrial injury and risk. So run risk assessments for specific work conditions on psychological well-being in the same way as physical safety. We don't think that's done at the moment. Gather and report data on health and well-being near misses. That might be challenging to do, but it could be looked at. And develop thinking on how to manage similar reporting on staff psychological well-being. So we feel that there's work to do here. And the analogy that was used with us is that sort of hard hats and things that protect staff on a building site, we don't have anything comparable for psychological ill health. So identify and nurture future compassionate leaders, identify a pipeline, provide support, role model and develop a compassionate culture, and take a long-term approach, prioritizing skills development and investment from students onwards. And learn from staff. This is creating a learning, not a blame culture. Work to develop and change culture, working with OD teams, create psychological safety and develop strengths, report back on actions undertaken to foster trust in systems speaking up. You said we did. Support the role of the Freedom to Speak Up Guardians and provide sufficient resource and support and board willing to hear and act on complex issues raised. I was part of the national evaluation of Freedom to Speak Up Guardians, and many of them had half a day a week to do the role and were not able to speak to the board, whereas others were full-time and embedded in the board. So way things are implemented make a big difference, and that's the same for wellbeing guardians as well as Freedom to Speak Up guardians. And provide and role model psychologically safe conversations and encouraging speaking up when things are not okay. So this diagram summarizes the recommendations and show how they fit with our final program theory. So this just represents all the things I've just been speaking about and hopefully gives a way to bring this all together. There's a section in the guide about what you can do, and there's 3 different groups. So 8 suggestions for senior leaders, and there's examples from each here. 9 suggestions for managers and team leaders, and 8 suggestions for nurses, midwives and paramedics. But we do want to emphasize we're not putting the responsibility back on individuals, because that's most of what the literature does. We're trying to take a different approach here and say that it's everybody's business, and particularly and including the board. So where can you get the guide? It's on our new website. It literally launches this morning. I think Kath or someone will put it in the chat if they haven't already. Oops, she's looking. Oh, I will in a minute. And then you can download the guide. All I'd say about that is that we're trying to capture impact data. So as researchers, we have to know how our evidence is used and whether you've downloaded the guide and used it. And there's just 4 short questionnaires before you can actually access and not 4 short questionnaires, 4 short questions to ask what sort of role you're in, which country you're in, and whether you would give us your email so we can follow up and ask what you thought of the guide, what improvements we could make, and how you've used it. So please, you don't have to give us your email, but if you will need to do that. So don't be thrown if when you go onto the website you're asking questions before we let you download the guide. And with that, please don't share the guide widely. We'd like everyone to come, or do share it widely, but we'd like everyone to come to the website to get it, because then we can count downloads and gather that data. So finding out more, the details of our funding award are here, and we can make these slides available to you. We've published 1 paper. We've got another under review, an overall paper under review with BMJ Quality and Safety. And the wow factors, we worked with Daniele and Karen, comparing the workforce organisation and wellbeing for doctors, nurses, midwives and paramedics. And that's the website, workforceresearchsurrey.health. But there's a particular link to the guide or to the Care Under Pressure 2 part of the website. So that was everything that I wanted to say. Thank you for bearing with me. I hope that was a bit of a whistle-stop tour through the guide. There's much more in there, but we hope it will be of interest. And I'm going to hand back to Kath now.
Thank you very much, Jill. And we're ahead of time, which is always a good thing to be. I've noticed lots of Q&A and comments and positive feedback in the Q&A chat, which is really great to see. And thank you to my colleagues for answering some of the questions as well. I was conscious of not typing while Jill was speaking because we're sharing a microphone, and I didn't want to do too much of that if you could hear the tipping in the background. But we will get to those questions. We're working on getting putting the website address into the Q&A. As presenters, we don't seem to be able to do anything other than answer questions, but we're working on that. But we will make sure you've got that website address to download the guide. So I'm not going to answer lots of questions now, because we've got a section later on, and you may have further questions, or some of your questions may be answered by some of our highly esteemed speakers that we're really lucky to have here today with us. So I'm going to move on to that part of the agenda, and I'm going to introduce, I'm just checking that I've still got Kate here, because she was having a few internet. Yes, we still have Kate. So I'm going to introduce you to Dr. Kate Kirk, who's our first speaker. She is wearing a few hats today. Everyone here, I think, is wearing many hats. So firstly, she's a registered nurse and a member of our project stakeholder group for Care Under Pressure too. And Kate has also studied nurse wellbeing herself as an academic, and is deputy chair of the Chief Nursing Officer National Nurse Wellbeing Group. So brings all of that expertise and perspective into responding to our guide. So over to you, Kate, and thank you.
Thanks ever so much. Yeah, it's such a treat to be here. So yes, my name is Kate. Absolute pleasure to be asked to talk to you today about what I feel is an incredibly timely release of the Care Under Pressure work and the guide developed by Jill, Catherine and the team. So yes, as a bit of context, a bit of background, I have a foot in all of the camps, so policy, practice and academia, and I'm a registered adult nurse, and for the last 12 years I've been working clinically in the emergency department setting, and I'm also a lecturer in organisational behaviour in healthcare at the University of Leicester, where I sit in the Social Science Applied to Healthcare Improvement Research Group, and like Kath said, I study healthcare workforce wellbeing. So I've only got a few minutes today, so I thought it might be helpful to kind of zoom in on one of the hats and one of the recommendations of the report, which stands out so incredibly brightly for me, particularly in relation to patient-facing clinical work and my experience of being a nurse and working with other nurses. So that is recommendation number 3, to normalise, anticipate and manage psychological ill health in practice, especially the normalising part, which I just want to sing from the rooftops. And I'll tell you why. So at about 2 a.m. on a very busy night shift in ED about 10 years ago, and by busy, I mean physically, cognitively and emotionally exhausting. I think by that point, I'd walked about 10 miles. We had dealt with multiple stabbings, cardiac arrest, domestic violence, safeguarding vulnerable adults, minor injuries and everything in between. And a very dear nursing friend said to me in passing, literally in passing, I think we were walking past each other, the trouble with our job is that every shift we are dealing with people having the worst day of their lives, one after the next. And over the years, as I've got immersed in research and policy, it stuck with me. The idea that it is normal in one day or even 1 hour to deal with the whole spectrum of human emotion, suffering, grief, loss, anger, hope, and elation. This isn't to say that every patient we come into contact with is having the worst day of their lives, although many are, but at the time they feel they are. And we, the nurses, midwives, paramedics, and the rest of the team are often the emotional sponge in those times. And obviously this doesn't even include the profound moral injury we experience when, because of system pressures, the standards of care we deliver don't align with the standards we set for ourselves. I guess most crucially, we're then expected by ourselves as much as anyone else that these experiences should not take their toll, need an outlet or support, and further still, feel guilty or inadequate when we do. The emotional component of healthcare is what makes us human, makes us care, and is subsequently critical for compassion. So I really feel like we shouldn't shy away from it, but as the report so beautifully says, anticipate it. The first step is to normalise human responses to emotionally complex and intense work, and the need to, as the guide states so well again, not to question if someone will experience stress working in healthcare, but think about how severe this stress will be and how it will affect them. So this isn't about having emotional outbursts in front of patients and families, although sometimes patients do long for a deeper degree of emotional connection. It's about all layers of the profession and system, again, as a report outlines so well, acknowledging that contemporary healthcare practice is emotionally complex. And I long for a clinical world where staff are able to say, wow, that was tough. I really struggled dealing with that. How did you find it? As easy as we say to Mrs. Smith, the next patient, don't worry, we will look after you. I've seen so many colleagues unable to hold in all of the angst, and worse still, suppressing these experiences can manifest as we know, presenteeism, compassion fatigue, absenteeism, or worse, and so often we lose great colleagues from the profession altogether. So the power of normalising support and, dare we say, embracing the emotional component of care is, I believe, so central to improving both staff and patients' experiences of modern healthcare. So it'll be unsurprising that I'm delighted to see this as a recommendation in the guide, coupled with really practical and tangible examples of how to make change, drawing on the integration of psychological health and education in undergraduate study, which I think is super important, long-term planning and individual development plans, like Jill said about the protective career breaks, and most importantly, normalising checking in with one another and having the space to hear the answer. So along with recommendation 3, the 5 other recommendations, I'll be sharing this report across policy and academia so happily, with the national and regional teams helping us to understand and tackle psychological health across the professions. Perhaps most pertinently, I will take page 29 to the nurses, midwives and paramedics and clinical leaders who I work alongside and tell them to read it, or I will read it to them. And I will say that you are exceptional and that you are doing difficult psychological work every day, and this report hears you. Thank you, Jill, Kath and team, on behalf of nursing, for bringing this together so poignantly. Thanks,
Wow.
Kath. Okay.
Thank you so much, Kate, for endorsing the work and the recommendations so strongly. I mean, we developed them in close consultation with our stakeholder groups, as Jill said, many of whom are here. You were one, and many of whom are here in the audience as well, to make sure that what we were recommending was from the literature was what was needed, and we really hope that it is as helpful and useful as you suggest it may be. And any feedback that you get and anyone else gets from sharing it, we are all ears. We want to continue to develop this work, and I'll be talking a bit later about at the end. I'll just tell you about what our next steps, our planned next steps, and how people may be able to help with that. But thank you so much, Kate. That was absolutely brilliant. So without further ado, I'm going to move to our second speaker. So I'd love to introduce to you Nina Kazaizaza, who is our second speaker. She also has lots of hats, as everybody has lots of hats here, as I've said. So as well as being a registered midwife and a member of our project steering group, our project stakeholder group, sorry, for Care Under Pressure too, Nina is also interim regional chief midwife for London within NHS England, and has led the development of the Capital Midwife Health and Wellbeing Blueprint for London maternity and neonatal services, which they're currently piloting. And I have had the honour of being able to see an early version of that, and I'm delighted to see this work going forward in London for midwives. So without further ado, I would love to hand over to Nina. Thank you.
Thank you, Kath, and thank you so much for inviting me. I'm delighted to be here because this is a subject very close to my heart, both as a qualified nurse and a midwife. And I feel very lucky.
Nina, you're very, very quiet.
Oh, am I? Can you hear me now?
Ah, yes, that's better.
Sorry, I'll hold on to this. Apologies.
No problem. Thank you.
So I think it's, I feel very lucky because in 2020, I was working operationally and I was leading on one of the maternity services as a head of midwifery in London. And also in October 2021, then I joined the region. And as part of my role in the region, I worked with a national, within the national team that were leading on the health and wellbeing project, people who sit within the NHS People Directorate. And as part of that group, we visited a number of providers, maternity providers in England. And so that really gave me a rich experience and an opportunity to consider the challenges from a broader perspective and through different lens, if you like, both policy and clinicians, and being subject to it. And seeing this guidance and the recommendations today, it is really, really lovely, because it really resonates with what I heard and I've seen, and really aligns with the capital midwife health and wellbeing blueprint, as we call it. I think Jill mentioned in her talk, as she in her introduction, that she made reference to the recommendations. As we all know, the vital interconnection between the well-being of our staff and the quality of care that we provide, in my case, women, birthing people, babies and families. And having reflected on this for today, there were two main themes that really stood out for me. One is around inequalities and the diversity of staff. And it kind of made me think the fact that we are not all born into equal circumstances or with equal abilities, but we all deserve to have equal opportunities, whether that's at work, is at university, as a service users, recognizing that most of us will be service users or are service users at some point in our lives. And the second point was that the world is always changing. Healthcare is always changing. We made reference to the complexity and the dynamics and how do we balance, and there is a need for us to be agile. And looking back at centuries, there's never been a time where there hasn't been a change, and the change is always faster than before, as we think. And we have seen it in the last few years with COVID, equally with technological advancements and AI, which give us new tools in the system to use, but equally has been very disruptive and amplify the challenges and demands on our staff. And it really did intensify the workload and emotional stress, and that rapid and the need for the rapid and adjustment and the agility within the system. So I think looking at it from a kind of a broad perspective, as the pace of change continues, all of us need to foster that adaptability and prioritize the staff health and well-being. And the tools and the recommendations in this guidance and this report are really, really helpful. I still work clinically, and I was reminded of the particular key finding around number 2 and 4, the serve and sacrifice, when I was observing, one of the matrons asked one of the staff who had already stayed an additional hour beyond her time to stay another hour, just another 2 hours, just to support a woman who needed to be induced. And there was a point that the staff said, well, I can stay another hour, but I do have a life and other commitments to consider. And it really made me to think that we always look at our patients, the women we serve, and we always consider them as in a holistic approach, consider their needs throughout the lenses of the person, whether that's social influences, the circumstances, as well as emotional, mental health, and their own physical well-being. But we don't really do that for our staff. So it's about how do we support and encourage staff to bring their whole self to work, and how do we support them holistically as leaders, senior leaders, and all of us are leaders irrespective of our titles. So I think the recommendations in this report will give us those guidance and consistency to support us to be able to do it correctly all the time. And I think the reference to the compassionate leadership is really important, because that really does give us that tangible and effective framework recognizes the human elements in our workplace, and also it helps the understanding of our teams that they're not merely a cogs in this organizational development, but they are individuals with diverse needs, challenges, and aspirations. I think one of the benefits of COVID was that we all received a number of packages of interventions focused on health and well-being. But again, thinking about the diversity of our teams, I always remember speaking to our staff from a different ethnic minority background that felt speaking to a psychologist, you think I'm mad, or mindfulness is not for me, I don't have time for that, thank you very much. And speaking to a chief exec in one of the trusts I visited outside London, they told me actually what we see is when we provide all of these mindfulness apps and other interventions, they're not really meeting the needs of our staff. What they want is having access to a dental care whilst they're at work, having access to a GP whilst they're at work. So that really does support them to be able to look after themselves equally as well, without having to feel the pressure or the guilt, as we often see, and that moral injury that we refer to here, to be able to look after themselves well enough. And I think one of the things that's really, really important to consider is, and you have referred in this guidance to compassionate leadership, that really compassion starts with self-compassion. And I think that's something we need to really instill in our staff, irrespective of where they are, whether they're nurses, midwives. And I think that's really helpful to have this framework to work towards and remember those and pause and reflect. We often don't do that because we're in constant mode of moving forward and don't really have the time to do that. But pausing and reflecting as leaders, how do we support our staff? Do we really see and hear, and do we really listen to the concerns, and do we give them the basic needs that they need? And when we developed our framework in London, what we found was that the most important aspect that everybody was talking about was having their break. You know, it might be really basic for us, but for them, it was having the time to go and have their break. That was the key point. And you referred to it here as rest and recharge. We called it refuel and recharge. And then I think it's just really important thinking about the basics and be able to build on that and build on the autonomy and support them throughout that compassionate care. So I think based on that, I just congratulate you all on producing this guidance, and thank you for focusing and highlighting and shining a light on this really, really important part that's incredibly important considering the workforce challenges we are all facing in healthcare. So really to conclude is again to say how important the focus on prioritizing our staff health and well-being is, and to really acknowledge that this is not really an aspiration, it's a strategic imperative for us to make sure that that really does take place. And I think from a London perspective, we've really committed to support and using the guidance which really aligns with what we have heard from staff and giving them some tools in order to be able to do it. So again, thank you so much, and that's where I'm going to pause.
Thank you so much, Nina, and I'm sure everyone will be dying to hear more about the blueprint as well, and the progress that you have with that as you pilot it and that spreads, and we'll be delighted to help support that as well. I think, you know, you drew on such a lot from the guide, and I think definitely thinking of some of the questions in the Q&A when you talk about having spaces for staff to just come together and decompress and just rest. Those were the sorts of, almost, that was an example, I guess, of informal interventions and WhatsApp group and things like that. So staff being able to just come together, and those spaces and places have been eroded over the years. And certainly when Jill talks to me about her training as a nurse, and reminds me of them all working together on shifts together, and then they'd all live together, and they'd all go out to the pub after their shift, or out for a meal after their shift, and those sort of informal spaces where staff are able to share the joys and the difficulties of the day help staff to deal with them. And of course, with 12-hour shifts and busy, you know, just the way workloads have changed and the way training and has changed, lots of those spaces have gone, and we absolutely need to make sure that we provide those informal spaces. And thank you so much for reinforcing lots else in the guide, but just picking up on that. So thank you, Nina. So I'm going to move us on to do continue to put questions. If anything is raised by any of our speakers, do continue to put them in the Q&A. We will get to those soon, and we'll be able to ask the speakers if they're able to stay. I know Nina has to leave at 12, so if you've got any questions for Nina, get them in that Q&A. And some of our other speakers may not be able to stay the whole time as well, so please do use that Q&A. So I'd like to invite you to our third speaker, Catherine Grayling. Thank you, Catherine. It's lovely to see the cameras pop on and people to see them. So Catherine also, everyone has many hats. I'm going to stop saying that in a minute. So Catherine is a registered paramedic and also a member of our project stakeholder group. Catherine was assistant director for NHS Employers and NHS Confederation as a workforce specialist, working with NHS people leaders to influence and shape strategic workforce policy. So has a very incredibly relevant role to all of this work. And she's recently been appointed Director of People, Culture and Organisational Development at the NHS North East North Cumbria Integrated Care Board. So the perspectives that you're bringing as a registered paramedic, and then through all of these strategic workforce roles, is just brilliant to have you here and to hear your reflections on the work and the guide. Thank you very much, Catherine.
You're very welcome, and I'm absolutely delighted to be asked to be both part of the work as it's been undertaken and to speak today as well. So hi everybody. Yeah, I'm Catherine. As it's been said, I'm a paramedic, but I having had a career spanning 25 years clinically, I did suffer a quite a significant breakdown in my mental well-being at that point. And, you know, through being involved in work like this and other studies like this, I've learned so much more about what happened to me during that time, and really powerful to see that reflected and as something that I can recognise through this guidance as well. I think, you know, what I and you know, many of us working in this area, whether it's through research, policy, you know, whether we're still working clinically or if we're in leadership positions, you know, many of us come to this because we've got this background of experience in this ourselves. And I think that's the first thing I want to say about this study. I think it's really powerful and really important to have people with lived experience at the centre of any work like this that we undertake. And throughout this study, that's been absolutely, you know, a core foundation of the way that this work's been undertaken. And, you know, that nothing about us without us really stands true to this, and I think really legitimises the work and the guidance that has come out of the study. For years, you know, following my breakdown, my salvation was around finding a new purpose and wanting to do something in this space to create a better and safer opportunity for others. But looking back now, I recognise that was probably just as much about repairing myself as doing something for other people as well. I think, though, you know, I look back now at my early efforts around well-being and the things that I attempted rather clumsily and think, gosh, I probably caused more harm than good at best. But even the things that did go better, I think, you know, we very much worked on it. Okay, we've learned that this has worked in this place for these people, so we can simply take that and we can put it into this new place, and it will work like magic, and people will get better and they'll be more resilient at work and they'll want to stay working for us and they'll be happier. And do you know what? This guidance helpfully challenges that belief for the first time, I think, forcing us to kind of look underneath something and really think about the culture and what will work for who and in what circumstances feels very fresh and brand new. None of us would have ever disagreed with things like Michael West's work on compassionate leadership, but actually digging underneath that to work out, you know, what will be required to make it work? Who are the people we're trying to work with? What are the circumstances and the context around us? Is the first time for me that we're encouraged to kind of look at what will either impede something's success or support its success as an intervention to support people. And I really welcome that within this work. So much of it really, really resonates with me. And I could pick out any one of the strands within this, but I really value the fact that they've been addressed as tensions within the work as well. I think, again, it's about that belief that something will work, but not quite understanding why it hasn't worked. And I think that is that deeper level that we're all looking for and engaging with now, and need to be thinking about as we look to introduce wellbeing initiatives and interventions for whichever part of society. I know particularly I'm working from an OD perspective around the culture of psychological safety at the moment. And that's easy to write down on paper, probably not easy to spell, but easy to write down on paper, but incredibly difficult to do. And you know, we're taking baby steps up in the northeast and North Cumbria around that at the moment. But you know, even if we can nudge things forward slightly along any of the strands that are picked up in this study, I think we'll be taking great steps forward, and it's a great foundational piece. Now, I know you've got a lot more speakers to get through, so I'm not going to take up too much time, and I'll call it a day there. But you know, thank you for involving me and all the others of us with lived experience in this study. This is a piece of work that we recognise, and actually there's really practical recommendations for how we can start to think about this in a different way. So thanks ever so much to the team, and really, really look forward to mobilising this out within the health and care sector. So thank you very much.
Jill putting her thumbs up there. Thank you so much, Catherine. And I can't state more clearly than I'm going to try, and my words won't probably do it very well, how important to have you and the others that shared with us in that very first stakeholder group your lived experience of the impact that work had on you psychologically, and that was underpinned our whole approach to this review, and our need to make sure we did something different, and that we were moved on from what we knew already. There was lots of reviews already, as we knew, about what the causes were, but they just weren't getting at the real nub of why are we not making a difference here, and why aren't these interventions working? And I think your stories, your experiences were just completely fundamental to that. I think Jill wants to come in.
I just wanted to totally reiterate that. I mean, I think for those of you who won't know, in our first stakeholder meeting, we had Catherine and others share their lived experience, and it was one of the most powerful sessions I've ever been in, and I'm a Schwartzman facilitator. So that says something. And I think what we heard that day absolutely galvanized us and motivated us to deliver this work, and feel, you can hear the catch in my voice, feel that it was important. Yeah. And as a nurse who burnt out and I thought left nursing, I heard it, and that's why we do this work. So thank you, Catherine.
I feel like I've got to give Jill a hug now, but I will carry on sharing it. I mean, it absolutely grounded us in the importance of this, not that we already weren't. We'd spent decades researching it up to that point, but I think it's never been so important as it is now to actually make a difference and to try and make a difference. So thank you very much, Catherine. So I'm going to move us on. We've heard from our sort of representative, for want of a better word, from a nurse, a midwife and a paramedic. And our next three speakers have got different lenses and perspectives to bring to this, and national roles to really help us think about kind of how it might be useful. And so I'd like to start by introducing you to Sian Kitchen, who many of you may know. Sian is the Senior Programme Lead for Evaluation and Insights within the Health and Wellbeing Programme for NHS England and NHS Improvement, and we've worked with Sian at arm's length and closer, hopefully soon, for a number of years, since first discovering the NHS Health and Wellbeing Framework, which we were delighted to discover, and to see that there was this framework that took this systemic approach that we really felt was needed. And so we've always appreciated Sian's wisdom and insights, and we're delighted to have you here today, Sian, to give your reflections on the work that we've done. Thank you very much.
Yeah, thanks, Kath. And I'm absolutely delighted to be here. Thank you for the invitation to speak and to kind of help launch this guidance. And I just want to reiterate what Kath and Jill have just said. It's an absolute privilege to follow on from Kate and Nina and Catherine, and to hear their perspectives, their lived experience, and the lived experience of nurses, midwives, and paramedic. It really brings home how important this is. My job at NHS England is to help keep everybody focused on the evidence for health and wellbeing. So as Kath and Jill know, I've said lots of times, I'm so pleased that this report is being launched, and that it's based on really thorough and really wide-ranging research across the whole subject. As we know, and as we've heard, too many nurses, midwives, and paramedics experience poor mental health and psychological well-being, and often that is, as a result of their work. That's historically been the case. I'm really pleased you mentioned the health and wellbeing framework, Kath. But we do know that the national response historically has often been quite narrow, but we know that there are lots and lots of ways we need to come at this to support staff. We know, and as has been mentioned, the COVID pandemic had a huge impact on staff, and we know that pressures on the workforce continue, particularly in areas such as urgent care, and that is continuing to impact staff. So without that ongoing preventative and supportive action, staff will continue to experience poor mental health, sadly. There are some green shoots. We know that the rates and the absolute numbers of nurses, midwives, and paramedics who are taking sick leave for mental health reasons are now lower than they were in 2021, but they are still higher than they were in 2019 before the pandemic. We're also seeing some signs of that shift in culture. In the 2022 staff survey, we did see slightly fewer nurses, midwives, and paramedics tell us that they'd felt pressure from their manager to come into work when they were unwell, which is really promising. And that was a lower number than in 2019. So that shift in culture is starting to happen. It's small shifts, though. Those are positive signs, but there is more to do. We absolutely mustn't be complacent. And one of the things that I and my team have been, really clear to say is health and wellbeing isn't done just because the pandemic is over. We really need to keep a focus on that. It is included in the NHS long-term workforce plan, I'm really pleased to say, which from a, I think, strategic and policy perspective will be the only game in town, at least for the time being. In terms of this report, then, I'm really, really pleased to see all of it. And I've got a long list of things I'm really happy to see in it. The focus on prevention, that focus on getting the basics right, which, doesn't happen enough, and we mustn't lose sight of, on listening to what staff need rather than assuming we know what they need, on organisational and systematic approaches, and that's going to be particularly important with the role of integrated care systems going forward. And I think related to that, the role of supporting leaders. Many of those taking these leadership roles in integrated care systems will need that kind of support. The importance of culture, which has been mentioned a lot. I was really pleased to see that you've covered the aspect of emotional labour. We haven't really heard that mentioned particularly in terms of the impact of COVID. We've heard a lot about moral distress and moral injury, but not about emotional labour. So I was really pleased to see that there is a focus on that element of people's work. And finally, and probably most importantly, actually, on the role of managers. It's probably the most important relationship somebody can have at work that supports their well-being. So, I mean, I came into a staff health and wellbeing role in April 2020, and we saw that huge kind of response nationally in terms of how we responded to the health and wellbeing need, but also from, you know, from society as a whole. You know, and that was incredible. I think that is a little bit under risk. I think there is a risk of complacency or focusing on, you know, other areas, given all of the different pressures that the NHS is under. So I'm going to finally reiterate what I know others have already said, that this report and this guidance is therefore incredibly timely to help us keep that focus on it. And I hope we can collectively commit to reading the report closely and to taking forward many of its recommendations. Thank you.
Thank you so much, Sian. I know you wanted to share a slide. We have got time if you do want to do that.
I won't share it.
Okay.
I might go and pop it in response to a question or something if I'm able to.
Okay, yes, okay. Or we can send it
really
out.
Just to kind of describe where we are in terms of the current organisation of the NHS national system, which we know has always changed. But it was really just to stress that a lot of the responsibility for staff and staff wellbeing and workforce will now go to integrated care systems. So I think it's really important that we share this with them, and I will certainly do absolutely what I can to facilitate that. Thanks, Kath.
Thank you, Sian. And what a brilliant end to what you've just said, leading into our next speaker, who I'm going to introduce now, Kevin Croft. And the reason that's a brilliant interlude is because Kevin, as well as everyone else wearing these different hats, is Chief People Officer at Imperial College Healthcare NHS Trust and for the North West London ICS. But he's also the lead for the Chief People Officers group within the National Shelford Group. And so in terms of links into ICSs and Chief People Officers and leads for wellbeing, Kevin is a great person for us to have here today. And we have the pleasure of starting to work with Kevin more closely on our next steps, which I said I'd come to at the end, which I will. So we're delighted to have Kevin here today to give his perspective on this. Thank you very much, Kevin.
Thanks, Jill. Yeah, and thanks for inviting me. It is an honour to be here, as other people have said. Going slightly later in the running order, I also would say a lot of all of what everybody else has said, I think I would agree with. Looking at this from a sort of practitioner's perspective, I suppose, it's a great piece of work, and as others have said, it's very timely. It's really helpful to have a guide as a practitioner trying to run hospitals and other organisations. Having something that's based on the latest research in a accessible, short, format is really invaluable, because we don't get a chance to access sort of primary research and research papers and academic journals and things like that. So the guide it's really great, and I love the graphics, and I think Jill mentioned that. It's really good to see some of that imagery in there. As other people have said, this is a really important issue. We've had the publication of the long-term workforce plan, and there's lots of, as the name suggests, long-term goals and aspirations about growing the workforce and reforming the workforce and training more people. But obviously, one of the key things that we can do immediately is keep more people. Both keep more people at work and thriving at work, as well as keep people, a couple of people have mentioned actually, leaving their jobs probably earlier than they would have liked to have done. And I think that is happening all over the place. I think is that people are saying, I've had enough, I'm going to go early, or I'm going to take my pension. I wasn't planning on going this early, but I'm going to go. And so I think this is really timely. I'm learning more about the realist methods as we start to work together, but I think that it's really valuable, that contextual part. And I think it was Catherine that mentioned this as well, is the tensions, I think, is a thing that I've not seen before reflected in a piece of work like this that really resonates as a practitioner. we get lots of advice, we get lots of, saying, you need to do this, you need to do that. But often, as you've picked up, and I really love the tension, and then the way that you say, you have to do this, but then that has to be matched by that. And I love the jigsaws, because that is often what we're facing, is we sort of sometimes know what we want to do, but we have to work and navigate the trade-offs between, and as you've identified, the system and the individual and the balance, we have to try and navigate the trade-offs between that thing we want to do and this thing that might be a constraint or a restriction, and to then identify, well, actually, it's both and. I think one of the things that I've said in the last 6 months, working both at the organisational, collaborative and ICS level, is telling people it's not either or. It's not either employers should do this or the system should do that. It's both. Employers need to do this at their level. Collaboratives need to do this at their level. ICSs need to do this at their level. The region needs to do this at their level. And then nationally, this is the added value. So I think that the way you sort of identified that is really important. And then what's really helpful in these sorts of documents is some roles and responsibilities for different people in different parts of the organisation. And again, reinforcing what was said about line managers. We know it's the old adage that people don't leave their organisations, they leave their bosses, is still what we see on the ground. And some of the work that we've been doing at Imperial, we've got some programmes that are for what we describe as anybody with a responsibility for another human being. And first of all, that's important because that means that if you're a band 3 domestic supervisor, you have a management responsibility. It's not about just the 8s and the 9s and the execs and everybody else, although that is important as well. So it's both and again. But I think anybody that has that responsibility for another human being, not a worker, an employee, or a human resource, but another human being. And what you've got in the guide really hits to that, the fact that our staff are human beings with emotions and needs that we need to look at more closely. I mentioned the contextual factors. It's great to have the recommendations, and I think they do add value. And looking at those at both Imperial and in the ICS, I think they challenge us, but they are potentially achievable. I can see us achieving them. Sometimes we get reports that are sort of almost a bit theoretical and don't seem to understand the reality. I think these are embedded in reality and are possible to deliver. And I've certainly already started talking to my fellow lead at the ICS and also the health and wellbeing lead at Imperial. And I think what we will then do, and there's some people on the call today from London as well, is that then look at how do we contribute through Shelford and other places to the regional and national work that needs to be done. One caution, I think, from the guide, I think this is mentioned earlier, where you've aggregated up to the tree, once you start to get into that phraseology, culture, that's big stuff. And I think the only risk is that perhaps senior people might say, oh yeah, we're doing loads of work on culture, or we're doing loads of work on managers. I think there's just a bit of a danger if they only focus on that bit, it gets lost with all the other stuff. But I think it's been coherent, comprehensive. Sorry, this sounds like the X Factor or something that I'm just doing a little bit of a. You'll be going to judges' houses, no doubt, so don't worry. But don't let people get sort of off the hook by focusing on the tree rather than the jigsaws. And then I think there's also, in terms of wider and next steps, and I think Stephen's about to speak, so and me and him have been in this game for a long time together, is that using the staff survey as both the evidence about where we need to focus attention and the potential impact of interventions, I think will be really necessary. And I might be creating a rod for my own back here, but again, Stephen and Sean will have more input on this. But conversations with the CQC about well-led and what they expect from organisations around staff health and well-being, I think this document actually is valuable, along with the other things that I think Sean was mentioning, to sort of hold some accountability. to employers and systems. So I'll stop there. But yeah, lots that I really liked, and just 1-2 bits of caution.
We're delighted to hear that we got through to judges' houses. That's amazing, and we're all smiling at that. Yeah, we listen to this, as we always do, to your wise words, Kevin, and perhaps we need to remove or focus on the other diagram that represents the tensions and the recommendations all in one, so that the tensions don't get lost rather than the tree. But I guess what we want people to take from the tree is that you've got to start from the roots up, and that systems approach means that they do have to address all of those things. But yeah, we're always trying to find kind of clever ways of illustrating complex findings, and just to pick up on what you said about the managers as well. I think one of the key things we did find in the literature is that we obviously agree with everything you said, but we've also got to look after the managers and the leaders, and there's that kind of, you know, they can feel very alone, and very like they have to be the shock absorber of this disjuncture between the pressures on them to deliver a service, but also to support their staff. So I think we absolutely need to kind of find a way of it's a wicked problem, and there is no easy solution, but I think with us all working together, as we are doing and have done and are continuing to doing, I'm hoping that we'll make progress. So it's
I think that one of the things, actually, just coming back on that, I didn't mention it. I wrote it down and then bottled out of saying it, but I will say it, is that how the system treats the senior leaders has this type of impact on the senior leaders, as well as how they behave. Totally. You know, as we know, certain things trickle downwards, and so it's been a knotty issue that gets spoken about sometimes, then gets sort of ignored, and I think that would be something that we need to think about. But even me not saying it indicates the fact that that is a tricky issue, and how do we speak truth to power about the behavior of the system leaders towards other system leaders in other bits of the system. Yeah, that's probably all I'm going to say.
Definitely. Sorry, do you want to?
Having done another project where I interviewed a chief executive who, you normally only get about 10 minutes of a chief exec's time. I think we had 90 minutes. I was rather surprised. And actually, it was almost a therapy offloading session, because that person we subsequently found out, it became in press, was being bullied by the old SHA and was having a lot of target. I mean, you know, this can go on at any level. Just to say that we launched last month our guide on unprofessional behaviours. I put that in the Q&A, which also tries to address some of these issues, because they are very interlinked. You know, people experiencing unprofessional behaviours, bullying, harassment, incivility, microaggressions, really affects their well-being. But I think we recognise that, and we know that there's a revolving door of senior leaders, and there's a reason for that. You know, you can't stay in these top jobs very long. You've obviously cracked it, Kevin. You've got some longevity there, so we'll learn from you about how to stay in a top job and a senior level for a long time. But you know, nationally, we've also heard about bullying and poor behaviours and pressures in government. So it goes all the way to the very top, doesn't it? So nobody's immune from this, and we recognise that. And I think we were really trying to be careful not to kind of be us and them and blame others. We mainly heard from frontline staff in our stakeholder groups, although we did have senior leaders too. But you know, we really need to be careful, because it's and as well.
Yeah, absolutely. And role modeling is obviously a really, really effective intervention in itself, for staff to see that managers are caring for themselves, and you know, self-compassion, and yeah, I think it's important to say. So you already semi-introduced our final speaker, but it's without further ado for me to properly introduce Stephen Weeks. Just putting his camera on. So Stephen is policy lead at NHS employers and leads on work relating to the NHS staff survey, as you've heard. And I've seen Stephen has replied to some of the messages in the Q&A in relation to that. So he's very familiar with the long-standing issues relating to poor psychological well-being for nurses, midwives and paramedics within the NHS and indeed all staff within the NHS. And he also has a brief to ensure employers are aware of our latest, not just ours, research evidence. So we're very much looking forward to hearing his thoughts on our work and on our guide. So over to you, Stephen, and thank you very much.
Thanks very much. There've been a couple of references to hats, so I thought I would wear my hat, as Kevin knows.
Brilliant.
I'm
going to go and find one.
So this hat is in as part of the NHS Employers Staff Experience Team, which is where I'm located. I'm not a health and wellbeing specialist, so I will definitely defer to others on the call in terms of the expertise on health and wellbeing, but I have represented NHS employers on the NHS Staff Survey Advisory Group for more years than I care to mention, but it's almost approaching 20. And within that, health and wellbeing has always been a central feature of the staff survey, and NHS employers have always had a central focus on improving health and wellbeing, working, hopefully supporting people like Kevin and Catherine who actually do the work on the ground. With that, I'll take that hat off and speak a little bit more personally, because I was inspired by what Catherine said, which is also just to bring in lived experience. I had a lived experience of having you can call it a physical breakdown, but it had mental health consequences, which I didn't recognise at the time. And I think that's this was about 7 years ago. And I think those two things are intertwined, and we've perhaps had historically a bit of a unnecessary and unhelpful dichotomy, even within an NHS staff survey, but between physical health and mental health. But we have begun to change that. And I think 3 years ago, we revised the questions within the survey to link them to what we call the NHS People Promise, and particularly we revisited the health and wellbeing questions to see if we could make them broader, and we introduced a measure. I know there are views about it, but it was grounded in some evidence base on burnout, which is a self-declared level of burnout, and that established for the first time. We'd had research studies and obviously anecdotal evidence before, a sort of initial level of burnout, which we could then work to try and reduce, which showed, unsurprisingly for people who work in the service, a very significant level of burnout. I would say bordering on the chronic in an organizational sense. We've made very little progress at overall level, but some trusts, and I would not to put Kevin on the spot, and I would definitely highlight work at Imperial, for example, and also in the Northeast, have made significant progress. And some areas, and I'll particularly highlight ambulance services here, have made measurable significant progress at a sector level. So these issues are very, very difficult to shift, and particularly at large scale, as you will know, with large scale employee surveys, to see a shift in national results is quite difficult. But when you look at individual organisational results, you can see impact of interventions. As you say, not all the interventions have the impact that sometimes you would hope. Some of them, I won't name any individual organisations. There are some consultancies that claim regularly, every now and again, that this new thing is the single best approach to health and well-being. I'm sure all those things have value, but I think there's a bit of a tendency to jump on a bandwagon, but this intervention is going to be the one that's going to solve everything. And I think that the overall approach set out in the analysis, linking research, overall framework and interventions is absolutely the right one, and we'll do everything we can to share that with the relevant colleagues across the service, get their input on it, continue to have dialogue about the way it can be applied. I would definitely, for example, draw attention to the role of line managers, and NHS England have recently done an exceptionally good piece on how HR line managers can work together, and that includes quite a significant section on health and well-being. And so I've tried to respond to some of the questions. For those of you who've got an interest in data, the NHS Staff Survey is publicly available data for every organisation. There's a wealth of data in there, and there's definitely, and I'm sure the researchers in the call will welcome me saying this, there's definitely under-researched aspects of it in terms of what correlates most closely with what. And we've been doing some work around the retention issue to try and see which factors have the most impact within staff experience on retention. All of it does. It'd be helpful for practitioners to know which areas have the most impact. And equally, individual organisations have been doing a lot more work to understand. So they may have an overall average score that's around the average for the NHS, but almost certainly they'll have massive variation within their organisation, even perhaps within directorates. And what can they share? And perhaps just historically we've tended to go to the areas which are less good than the average and perhaps come and tell them why they're not doing things well, rather than going to the areas which are better than the average and seeing what we could learn from them. And I plead guilty to that as well. But we're trying to change that now and focus on learning from those people that are doing well, as also understanding and trying to offer support to those people that are doing less well. And to come back to Catherine's point, the transition to integrated care systems has been a bit of a bumpy one, but, and I didn't say that, I said that personally rather than officially, but it's definitely the right approach. And the overall approach to health and social care across the health and social care workforce, and obviously we don't have time to go to the social care side of things here today, is definitely one that a lot of integrated care systems are really thinking about, looking at what they can do and trying to ensure that the inequalities in provision of health and wellbeing support are addressed, because we have challenges in acute and community trusts, but they are magnified even more so in primary community care and in social care. But I can definitely see there are examples of positive impact from interventions, particularly where people have been able to apply an overall approach of a strategic framework, and I like the way Kevin expressed it, and individual interventions to address needs in particular services. And last but not least, coming back to where we started, maternity remains a huge challenge, and often in the news, sometimes not for the right reasons, but I think we would all pay tribute to the amazing work that people in maternity services do every day in a situation of very long-term chronic staff shortage, which hopefully are just beginning to be addressed. And I think London's done some great work on that in a way that we could turn around that sector, which is very much at the front line of these debates. So I hope that's given a bit of an overview about our perspective on it. Very happy to respond to questions in the chat, and we work very closely with colleagues in NHS England, and we'll be very pleased to share this piece of work with colleagues in the service and get their response and their work with them to help make a difference with it. Thank you.
Thank you so much, Stephen, for that offer and for all of your insights there on the guide and on the work. And I guess what I'm taking from it, one of the key things I'm taking is again coming back to this importance of context. And I think a lot of the time, and for good reason, people just want to be told what to do. Here you go, here's the intervention, implement this and it will make a difference. And I think what we argue, and others have argued before us, and what we've provided the evidence for, is the need for sort of packages of interventions that fit the context, and the context at individual level, the context at organizational level, the context at systems level. I know that work within Care Under Pressure 3, which Daniele referred to at the start, is taking that forward, and we sincerely hope that we will as well in the work that we are moving on to. So Stephen, you've got your hand up, do come back in. Oh, you're on mute.
Sorry, that's unlike me to mute myself. Just pick up a point that Kevin mentioned. We're an advisory and supportive body. There is also the regulatory role of the organisations, particularly the Care Quality Commission. To be fair to them, I think they are reviewing their approach to these issues, which have historically been quite safety focused in a quite physical sense. We have a much broader approach on health and wellbeing, and they are very keen to look at available evidence base. So I'm sure they will be interested in this work as well.
Excellent, thank you. And we'd be delighted to speak to them and share it with them, and anything we can do, to help with that. And I guess that's one of our tensions, isn't it, is that professional regulatory kind of need to ensure patient safety. Of course, that's really, really critically important, but that needs to be balanced with making sure that staff feel safe to speak up and to make mistakes, and to not always do the right thing, because it's an incredibly difficult environment that they're working in. So yeah, brilliant. Thank you very, very much. So that brings us to the end of our speakers, and we now have time for answering some questions. And I don't know, some of them will be directed, I think, to us as a research team, and some of them to some of our speakers. We've been answering a lot in the chat, but I know Jill's been frantically capturing some for me to try and share here. And I'm just going to go through them in no particular order, and perhaps see who out of our speakers might like to answer some of these, because some of them certainly aren't for me to answer. So the first one on my list is, have there been any successful cases of staff suing trusts for moral injury? I wouldn't know about that. I think that might be Kevin.
Sian's got a hand up.
Oh, Sian, Sean, you put your hand up?
I mean, I'm not going to pretend to be an expert on this. I'm not a psychologist or a psychiatrist, but my understanding is that moral injury isn't a clinical diagnosis. It's something that happens to people that they experience in response to those workplace pressures that we've talked about, which can, if people aren't well supported, contribute to mental health conditions such as depression, anxiety, PTSD. So I'm not aware that there are any specific cases, but there probably wouldn't be called moral injury because, as I've said, that is it's not a clinical diagnosis, but it would be something that could potentially contribute to a diagnosable harm. I'm not immediately aware of any cases. That's as my understanding of it.
Thank you, Sean. I think there's no one else with their hands up, so I think you've covered the answer as anyone else would have done. We have a question or a comment really for Stephen here. Could you share your work, your references to the work that you referred to on line managers? I don't know if you've got it to hand and you can put it in the chat. Or
Thought I'd put that in the chat. It's a new publication from NHS England.
Okay.
Expectations of line managers. I would stress it's an NHS England publication with input from a range of stakeholders rather than an NHS employers publication myself. I think it's a great piece of work.
Thank you. If we are able to put in the chat links to everyone, and you'll see I've now put the links to the Care Under Pressure 2 guide and also our Unprofessional Behaviours guide in the chat to everyone. So that's an easier way, I think, of...
Sean's put it in the chat as well.
Oh, she has. Great.
Yeah.
Thank you, Sean. Sorry, I haven't looked at the chat for a little while.
I'm not sure that. Do you want to do that?
So there was a question that I think I'm slightly struggling to see might be me and being host or something. You think I'll be able to see everything, but I'm slightly struggling to see the questions that have now been answered. But anyway, there was a question about triggering sickness penalties versus looking after yourself. And I suspect someone has answered that I didn't see the answer. So I think, Catherine, you might have been typing to that. I don't know if you want to speak to that or anyone else from an HR perspective.
Yes, I did reply, Jo, because I've been working with the chief people officers across the northwest of England. They spoke about an intent to kind of do more about presenteeism and supporting the 95% of people within work rather than just focusing on the 5% of people that unfortunately become absent. But part of that work was around the culture and the impact of having triggers in a formal absence policy. So they were trialling quite a different way to look at that in removing triggers. So worked with trade union partners to make sure we were all joined up on this, but worked to remove triggers in order to support a culture where conversations were much more personalised, so there wasn't a standardised application of policy to individuals, because what we'd heard from many staff was that their particular circumstances, although they'd been a very had extremely good attendance for all their career, something like cancer or mental well-being had interrupted that, and actually that standardized application had not either served the individual nor served to retain them within the service. So really, really interesting work, and I'm happy to connect anybody that would want to know more about that. It's very early still, so there are no outcome measures that would support whether it's been successful at this stage, but happy to connect you to CPOs that are doing this quite different work.
Thank you, Catherine. Thanks for the offer. And I see you've put your email in the Q&A, so very grateful for that. So yes, cool. I'm just about to speak. Oh, excuse me.
I think Stephen wants to.
Stephen, did you want to come in?
Just coming in relation to the issue of presenteeism, there is data in the staff survey by organisation of people reporting attending work when unwell, and we've tried to encourage as much emphasis on that as there is on data around absence levels. Obviously, I'm speaking entirely personally in the next comment. It is challenging to do that when the only government target relating to all public services relates to absence levels. So understandably, leaders of organisations feel very much under pressure to reduce their absence levels. But we have tried to highlight the connection between presenteeism also feeding into health and wellbeing challenges within organisations. And interesting to note, during the COVID pandemic, there was actually a significant drop in people attending when unwell, because we had quite strong initially guidance that you shouldn't attend when you have a communicable, potentially infectious disease. And I think I would also say, just people are aware outside, we have seen a reduction in perceived pressure from managers to attend when unwell. Most people list the reason they attend when unwell as being their commitment to the service, which is admirable in itself. So it's not, generally speaking, a question of being pressurized by their line manager to come into work. It's because the pressure to provide a service and their commitment to their patients and users is such that they do come in even when perhaps they shouldn't. And we are continuing to emphasize that that's not long-term a good thing in terms of health and well-being, and to try and support a change of the culture around that.
Thank you. Sorry.
No, you go ahead.
Sorry, I'm starting to chair now. Apologies, everyone. Thank you. You'll see I've put a link to the part of the website that's about unprofessional behaviours between staff, and somebody has said they can't download that document. My apologies if that's the case. Even if you filled in the 4 questions, we will look into that. It might be because that short questionnaire had just gone up overnight and it's interfered with the ability to download that document, but Justin and I will look into that. So apologies, but it will be back up shortly. So do check back. As you'll see on the whole website, there's this project, unprofessional behaviours between staff and the impact of COVID on nurses during the pandemic. So there's 3 projects on there now, and they all have guides, and one even has a couple of films. So just picking up a couple of questions, other comments. So time for the PNA, and I would also probably say PMA role, and I've also heard from colleagues in practice about the inability to attend sessions. So it's all very well having these roles, and I don't know if anybody wanted to pick that up or comment on that. I mean, I've definitely heard that from practitioners and in other sessions. I mean, that's always the challenge, isn't it, when there are interventions and you put on support for staff, is actually getting away from work to attend. And we certainly saw that in our national evaluation of Schwartz rounds, where certainly ward-based or patient-facing staff found it really difficult to get an hour away from practice to come and attend Schwartz rounds, particularly nurses and healthcare support workers. Kate, do you want to come in, and then Kevin?
Yeah, no answers, unfortunately, in terms of solutions, but I think they're certainly with the regional work I'm doing in the Midlands, people are trying to be really creative about supporting staff to access different initiatives. And sometimes that's the integration of those in kind of mechanisms that already exist. So whether that be mandatory training, or one of the ED departments I work with, they have training days for staff, and they've changed one of the training days to be a wellbeing day. And that's not to say that that's a solution, it's once a year or once every 6 months, but I think the point and arguably the strength comes from the integration and the kind of drip effect of these initiatives and just the general conversation around wellbeing being woven into stuff that already exists, as well as being standalone. So it becomes more normal, you know, whether that's at roll call in the morning, it's all of these little opportunities to kind of, you know, weave it in, as well as, wouldn't it be wonderful if everybody could attend a Schwartz round if they wanted to? So I think it's a mixture of both. It's like your puzzle again, isn't it? It's the system stuff and the individual stuff both being super important. I would also make the point that as organisations and leaders understand the value of wellbeing initiatives, it gives them the justification and the ownership to be able to feel like they can prioritise it over other stuff. So I think the louder and the clearer the message is, that helps full circle. So
thank you, Kate. And yeah, and I guess it's understanding the initiatives and also understanding the barriers for some staff to them, so that creative ways can be thought around, you know, how you can ensure that staff that do want to access them can. And just going back to Schwartz rounds again, so we found that lots of staff, you know, they don't even have an hour break, let alone have an hour to come off the ward and go to a Schwartz round. But it might be that permission could be rotated so that staff cover each other, so that you might not be able to go to every single round, but you can go every so often. And also the Point of Care Foundation have created sort of pop-up rounds as well. So it's about knowing what the gaps and the barriers are as well, and making sure you're aware of those, because one size isn't going to fit all, as we've been talking about today. So thank you, Kate. So Kevin, you were next, and then Catherine.
Yeah, I don't know whether it's another route for the tree, but the basis, I think, of a lot of these is the staffing levels. Is, so reducing the vacancy rate and having enough staff is the foundation of a lot of things. I always say, it's not just because my mum was a nurse, that the foundation of patient care is the staffing levels in nursing and midwifery in hospitals. Because without that, if you've got big gaps, then people don't get the breaks, they can't go on the training, the rostering doesn't get done because the ward manager is in the numbers. It's so fundamental. So having enough staff is just the foundation, really, or the roots if it was a tree.
Kevin, I don't think anyone will disagree with that thorny issue of all our thousands and thousands, tens of thousands of vacancies in many of our professions, and absolutely has to be what's sorted, and retaining those that are in there, which you've referred to earlier as well. And that's what lots of this work is driving at. Catherine, did you want to come in?
I did. So a couple of points that probably back up what Kate was saying, really. So I think this is it with all our wellbeing interventions. We know that there's only a certain percentage of staff that actually have awareness. Of those staff that are aware, there's even fewer that have the ability to access them, even though we know that a huge proportion, when they do access them, experience significant uptick in their well-being, ability to be at work and support others. So we know the case, and we've actually got the language to talk to boards, to chief finance officers in a way that they understand around the return on investment for releasing staff. But I think even though we've got that language and that way of talking and the evidence base behind it, it still feels incredibly difficult. And I'm just reflecting that in within patient care, particularly across health and care now, we are starting to talk about shared risk, and I'm wondering whether this is a concept that we need to be thinking about in that continuum between patient and staff. And reflected in your study was that tension between looking after others and looking after self. But I wonder if that needs to be more explicit in, we agree to undertaking some measured risk for patients, because we know that actually if we look after our staff and prioritise that, even though it might feel a little bit risky, the longer term outcome will be much stronger for organisations, for safety culture and for everything else. So I guess it's just something to think about for those of us that can work to influence leaders and work at that board level.
Sorry, I muted you.
We're both muted. We're in the same room. Thanks, Catherine. Thank you. Really, really important and helpful. One other question that had been in the Q&A that I just wanted to pick up was somebody had asked any issues about staff from different cultures. I think what I'd say about that is that is not well addressed in the literature. There was very little about that, and we found exactly the same in our unprofessional behaviours work. We do know that staff from other cultures and disabled staff and LGBTQIA staff, for example, are disproportionately affected by unprofessional behaviours between staff, and staff from other cultures experience microaggressions, and we know women experience misogyny and sexism, and we've seen the reports recently about the effects on female surgeons. So I just wanted to bring Justin Ornger in, who helped facilitate this webinar, but also led the work on unprofessional behaviours, just to say a little bit about that, because again, there wasn't enough or much in the literature. Justin, I don't know if you want to say anything on that.
Yeah, I think Jill has done a great job of summarizing the findings around that. We looked at all the interventions around the world that had been conducted to understand what can be done about unprofessional behaviors in acute healthcare settings. And as Jill mentioned, there are quite a range of different problems. One of them, of course, was the fact that across the world, the data shows that minoritized staff experience these unprofessional behaviors more frequently, as well as people with disability and women, and not single intervention considered that in their design in any way. Similarly, I'm sure this is probably also the case with a lot of the CUP 2 interventions, although I have to say I haven't read the full report in detail, but that there's a lack of use of behavioral science really in setting out logic models, for example, for how different NHS organizations actually tend for their interventions to have an effect. And so really bringing in more of that evidence base that obviously Jill now is providing with her great work, as well as really instilling the concept of creating a whole causal chain from like, what am I implementing to what are my expected outcomes? These kinds of things are really essential, we feel, in these workforce related interventions. And so I'll hand back to Jill now.
Sorry. Thanks very much, Justin. Thanks for commenting on that. And we're working on fixing the unprofessional behaviours guide. I think it's happened overnight when we've put up the questionnaire there, so apologies everyone, but that will get fixed. So I know Sian and Kevin wanted to come in, so Sian.
And yeah, just very quickly, I know as Stephen would say, you can use, you know, there's a lot of data in the staff survey that you can look at in different ways, and as we've said, you know, the different demographic factors that affect people's experience. But there is a significant research study called UK Reach, led out of the University of Leicester, who were set up originally to look at outcomes for minority ethnic staff from COVID, but that research is continuing, and they are continuing to look at different aspects of staff wellbeing. I'll pop a link to that in the chat, but that work is ongoing, and they'll gradually publish more and more findings as well, I think.
Thank you, Sian. Kevin, do come in.
Yeah, I don't know the evidence base, just put my hands up about not knowing the evidence base, but so there's a action for you. But we're starting to look more at cultural intelligence, and whilst obviously protected characteristics are critical, there's also the understanding of different cultures. And in this space, what we're seeing and hearing is that different staff from different cultures will have different ways of expressing their needs or their concerns, or not talking about anything from their personal life at work. And so I think that broader understanding of different cultures, as well as looking at it through the protected characteristics, is something that we're starting to look at more. But again, as I say, just a practitioner, so I don't know the research evidence for that, and it could all be a load of rubbish, but that's what we're starting to sort of expand into, as well as looking at staff from different protected characteristics.
Thank you, Kevin. I don't know the literature behind that either, but it's definitely something we need to look into, and certainly it needs to be underpinning our work going forward. Stephen, do come in.
Again, the evidence base is a bit mixed on this. Sorry. Am I still muted? No.
No.
Generational differences in expectation and willingness to use different types of support are also potentially an issue. I don't want to over stereotype or over generalize, but I think perhaps a rush to online support because of the circumstances of the pandemic may not have necessarily been right for all groups, but certainly welcomed by some who are used to getting mental health support through online systems. And I think the other issue to throw in, we always have to make a reference to AI in these sort of discussions. I think there's both a positive and a negative potential of the impact of AI within healthcare jobs on mental health and well-being. That could be positive because we could use AI tools to analyze the data in a way that we've not really been able to do in the past. And it may make it much easier to provide direct support, but there could equally be negative impacts from the use of AI in healthcare, as indeed in wider society.
Yeah, absolutely. And I think, well, we're very aware of kind of our generation compared to the younger generation when we're thinking in University of Surrey, trying to advertise and entice students to come and try out a Schwartz round, and having to realise that actually they don't interact with emails, don't work. We need to think about things like Instagram, which I don't do. and different ways of contacting for younger generations. So I think generational considerations are really important, as well as everything else that we're hearing today. And go on. Okay.
Sorry, Kath. I was just going to comment on another couple of questions. Tracy's Curran's point about commenting on the fact that even if a department ward is officially fully staffed, the workload is still often prohibitive of people being able to attend Schwartz rounds and other interventions. And as the King's Fund report stated, I love this phrase, chronic excessive workload has become the pattern on the wallpaper we no longer see. Mm-hmm. And I guess I just wanted to comment personally in that over my rather long career as a nurse, I think work intensification, expectations from the public and demand has increased exponentially. I mean, it would probably leave you all gaping to say, mouth gaping, that when I was first a nurse, someone having a hysterectomy would be admitted for 14 days. That would never, ever happen now, as you all know. But what that meant was that in an acute ward, there would be half the ward would be recuperating and recovering and being, as we called in those days, self-care. I mean, hospitals are so hot now, as are other situations and other settings, that there's never a break. There's never patients who don't need 100% of your time and maximum care. So that work intensification, I think, has rather gone under the radar, and it's a really well-made point. I don't know if any of our panel want to comment on that as well.
Even
if I could come in on that,
yeah.
I think it is an under-accepted point by perhaps the UK Treasury and those people who comment on the NHS in the pages of broadsheet newspapers and on ill-informed talk radio programmes. But I think it's a tribute to the NHS England, and particularly to Amanda Pritchard at the most recent Health Select Committee. She did very explicitly say that there's a major increase in demand in terms of the acuity of patients, to use the technical term, and also in terms of the expectations of those who come into interaction with the service, which is absolutely right. We want to move away from a passive relationship, but it does create more demands on staff. And I think our current ways of measuring NHS productivity just have not caught up with that at all. And we do need to try and find better ways of measuring the productivity of the NHS to acknowledge that increase in demand. And I think the other factor that people are well aware of, obviously, we are also within the NHS a service of last resort where people can't get other types of service. So within many acute hospitals are people who are not able to access the proper mental health care that they should be getting in community-based settings, and also many people who should really be getting social care. We can have a long debate about the actual boundary between those two things, but it's more social care is what they need rather than a very expensive and not very suitable and not very recuperative NHS bed. Speaking as someone who spent 4 days trying to be discharged from an incredibly expensive NHS intensive care bed, and was very conscious of how much NHS resources they were using up because there weren't available home care services in the local authority, I was very well aware of it. But I was able to make arrangements myself because I knew where to go. But obviously there are a lot of people who are stuck in those positions and not in a place where it's helping their recuperation.
Thank you, Stephen. And I just wanted to acknowledge the other point in the Q&A about integrating wellbeing and psychological health as within part of workload. Wouldn't that be wonderful, rather than as an add-on or as an extra demand? And that, if we thought of that, that would have been another recommendation. But thank you for that, and thank you to Claire for putting the great resource about different generations, the Mind the Gap HEE reporting. We will be studying that further. So thank you so much. I think we probably need to draw this to a close and talk about our next work, Kath, do we?
Yeah, I think we do. I've been dangling that, haven't I, for a little while. So we are reaching the end of the webinar now. I mean, it's been brilliant from our perspective to hear the questions and to hear the speakers' reflections on the work, and we're really grateful to everyone for sparing the time at this very busy time of year, not that any time of year isn't busy, to come to the webinar. So thank you very, very much. So where we're going next, well, there's several things going on, but the main thing we're really hoping to do, and it all depends on funding, is to set up a sort of a workforce wellbeing research centre, and we're partway through a funding process for that, with many of the people that are on the call here today, and so I guess it's just really to reach out to those of you who are interested in this area to say, if we are funded, and even if we're not, we will continue to try and get funding to continue this work. If you're interested in being involved as in a stakeholder capacity, we would love to hear from you. And we want to make sure we get this right. We want to make sure that whatever we take forward is going to make a difference. So that's our planned next step, is to try and work very, very closely with those frontline staff, with the ICSs that we've talked about today, in our localities. We've pulled a national team together, so we've got ICSs from across England, to just try and work with them to implement and evaluate interventions that really will make a difference, and packages of interventions that will make a difference. So I see Karen nodding her head there. I can't remember the word we used. It wasn't packages, but bundles, that was it. Yes, definitely. So that's our next step. Please do leave your details with us if you're interested in us pulling you in. I think
my email in.
Jill's putting her email into the Q&A, and hopefully you've got the website address for downloading the guide now. Please feel free to give us any feedback on that. Please let us know how you've used it. We really want to know that it is useful, and as Jill said at the beginning, rather than sharing it once you've downloaded it, we'd really appreciate it if you signposted people to the website so that we can continue to see who's downloading it and who's using it. So I think that brings us to a close, and all that's left for me to say is a very, very, very big thank you, particularly to our 6 speakers here, and some of them have had to go, but thank you so much for giving your insights and your expertise and your reflections on this work, and for those of you that participated in helping us generate it as well, and to the rest of the team that are here. We're delighted to have reached a stage where we're producing something that we're hearing is useful and is going to help move things forward, and we look forward to kind of continuing this and continuing the change that's needed. It's never going to change overnight. We know these are big, thorny issues, wicked problems as they're called, but I think we just need to all just keep moving in the right direction. So I'm just going to say thank you very much. I think we've got 2 minutes to go, so we've managed to run this within time. So hope you all have a brilliant break, if you get any break over the festive period, and hope to see you all soon. Thank you very much.